Bismillahirrahmanirrahim. I'm going to talk about the upper limb assessment in cerebral palsy patients. I will talk about upper limb involvement assessment, which include range of motion, selective motor control, sensation, muscle pathology, global function assessment, and setting goals for treatment. كلنا عارفين ان أو في ذهننا إن cerebral palsy أو upper motor neuron involvement means adduction of the upper limb, flexion of the elbow, pronation of the forearm, and flexion of the fingers, the posture of hemiplegic or strokes. But really in cerebral palsy, the story is different. There is no classic pattern. Even in patients who have flexion deformity or flexion of the elbow and flexion of the wrist and pronation, the shoulder may not be adducted, it may be abducted. In patients with dyskinesia or dystonia, have very variable posture and deformities. The commonest patients we deal with them in upper limb and cerebral palsy patients are either hemiplegic or quadriplegic. Patients with diplegia usually have good function of the upper limb. And this good function of the upper limb may make them walker with walking aids. And in severe dysfunction of the upper limb, the patient is really a quadriplegic and not diplegic patients. Most of the diplegic patients, they use their hands, but they have some decreased dexterity and the ability to do jobs and function with their hands. The assessment include assessment of the passive and active range of motion of the muscles of the upper limb. The range of motion should include assessment of the shoulder, the elbow, hand and fingers, and thumb. Usually the most difficult topic is the hand assessment because the function of the fingers and the hand is integrated with the function and movement of the wrist. So we have to ask the patient to do an active range of motion and we assess the range of motion passively. There is a classification for the voluntary control of the hand. This is the Zanculi and Zanculi classification, but this classification could be used to assess the active range of motion of the fingers and hands. We have three patterns. The pattern one, there is active extension of the fingers with wrists is in less than 20 degrees of flexion. So I don't need flexion of the wrist more than 20 degrees to achieve finger extension. And this means like this girl, she can do full extension and she don't need to extend the wrist more than 20 degrees. And she can extend even more than 20 degrees. This is pattern one. And this pattern one means that the patient has good fingers and wrist extensors. And there is no flexor contracture. There is no shortening of the long flexors of the fingers. Pattern two, there is A and B. A means the ability to extend the fingers, but with more than 20 degrees of flexion of the wrist. But once the patient flexes the finger, he can do extension of the wrist, like this patient. Once he do flexion, he can do extension of the wrist. This is another example. To do finger extension, the wrist is flexed more than 20 degrees. But once he do flexion of the fingers, he can extend the wrist. What does this mean? There is good finger extensors, of course. There is shortening of the long flexors of the fingers or severe spasticity. And you can discover this by passive extension of the fingers and wrist. If you can achieve this fully, then there is no shortening. And in this case, the wrist extensors may be very weak. So the patient, to achieve wrist extension, he has to do finger flexion, and by the finger extensor, he can extend the wrists. If the long flexors are short, he has to relax them by flexion and then do extension of the wrist. So this pattern helps in diagnosing where is the problem. To select which muscle to transfer in this patient, if the patient can do active extension but with severe ulnar deviation, can do active extension of the fingers and the wrist but with severe ulnar deviation, in this position, the extensor carpi ulnaris subluxes volally and become flexor of the wrist and not extensor of the wrist. And this patient can benefit from transfer of the extensor carpi ulnaris. But if the patient needs flexion more than 20 degrees and with severe ulnar deviation, in this case, this patient may benefit from transfer of the flexor carpi ulnaris and not the extensor carpi ulnaris. Pattern 2B is the same. The patient can extend the fingers with wrist flexion more than 20 degrees, but cannot extend the wrist after flexion of the fingers. So flexion of the fingers does not add anything for the patient, and the patient cannot extend the wrist after flexion of the fingers. And in these patients, they have fair finger extensors, not good finger extensors like the pattern 2A. They may have short, long flexors, and this will be discovered by passive range of motion of the fingers and wrist. And of course, they don't have active wrist extensor. Pattern 3, there is no active control of the finger motion at all. So when we ask the patient to do extension or movement of the finger, they cannot do. They recruit the other hand to do the movement we asked for. So these patients are totally different. They don't have voluntary control of their hands. And the patient who benefit from surgery, the patients who have voluntary control, yani pattern 1 and 2, and not 3. 3, we don't have any functional tool to help them surgically. The next examination after examining the range of motion is to define the muscle pathology. What is the pathology of this patient from the neurological point of view? Classically, we have either spastic cerebral palsy, the patient has spasticity, or has dyskinesia. And this dyskinesia may be apoptosis, chorea, ataxia, dystonia, and weakness. And we have to demarcate these patients very well. We have to remember that all spastic patients, all what we see as spasticity, have some degree and some elements of dystonia with variable degree of dystonia. So we have to know that not every resistance to stretch is isolated spasticity. No, we sometimes have resistance to stretch, but there is element of spasticity, dystonia, and other causes of hypertonia. This is an example of dystonia. In dystonia, there is rigidity resistant throughout the range. It is not clasp knife rigidity, spasticity. And there is a fixed posture. The patient can change it with great difficulty. This is another example of dystonia. Look at the fixed posture. And dystonia is usually associated with severe impairment of the selective motor control of the patient, as we will see. The third type is apoptosis. So remember it is marionette-like movement of the upper limb and lower limb. The patient does not have good control. They usually have continuous passive involuntary movement. This is an example of a mixed patient. He has element of dystonia, element of athetosis, and some degree of spasticity. He does not have a good selective motor control and don't have a good control of his upper limb. Ataxia can be inferred from tests for ataxia, but in young patients, we have to look at the eye for the presence of nystagmus. So spasticity, you feel, athetosis, choroidal dystonia, you see, and the delineation between these two types, or either dyskinetic or spastic patient, is very important because we have to avoid as much as we can surgery in dyskinetic patient. Surgery in dyskinetic patient is very unpredictable, and releasing muscles for contracture in these patients may produce the opposite deformity. So we have to be meticulous, and we have to be very cautious in dealing with patients with dyskinesia. Sometimes in the upper limb, we can use the Botox as a test before doing surgery. How? Look at this patient with mixed tone. There is spasticity, dystonia, athetosis. We don't know if this patient could benefit of surgery because surgery will only address spasticity. It will not address selective motor control. It will not address dystonia or athetosis. So we did injection of Botox for the elbow flexors. And here the patient's improved, and he gets some improvement in his motor control of his upper limb, and decrease of spasticity improved him functionally. So this was an indication that this patient may benefit of surgical release, because we are afraid of doing surgical release and the patient develop the opposite deformity with the stiffness in an opposite direction. The third is selective motor control. What is the meaning of selective motor control? The selective motor control is the ability to do isolated movement selectively and to contract the muscle selectively. يعني أنا عايز أفتح صباعي ده أقدر أفتحه بدون ما أعمل أي حركة أخرى. عايز أفتح إيديا بالطريقة دي أقدر أعملها بدون ما أحتاج إني أحرك الإلبو ولا الشولدر ولا أعمل ليننج بالترانك. يمكن عشان أمثلها لكم شوية، لو انت بتلعب بلاي ستيشن مثلا وانت محترف ولعيب، فانت بتبقى قاعد وبتحرك صابعك وبتلعب بلاي ستيشن. لما ما تبقاش بتلعب مش محترف كده زي حالاتي وحد كبير في السن، لما تيجي تلعب بلاي ستيشن تلاقي نفسك بتتحرك، بتعمل ما عندكش الكنترول اللي تقدر تحرك بيه اللعيبة على الشاشة، فده بيخليك تركروت other movement. ده برضو نفس العيان اللي عنده cerebral palsy لما بيبقى عايز يحرك صوابعه، عايز يمسك بإيديه، عايز يعمل كذا، بس بيضطر إنه يعمل حركات أخرى مش مطلوبة. this is poor selective motor control. في أنواع منه، في درجات، وفي assessment. The presence of mirror movement is an indication of poor selective motor control. لما تلاقي العيان بيحتاج انه يحرك مصل جوينتس اخرى يبقى ده بورس. لما بيحتاج يلين ذا ترانك مع الحركه يبقى ده عنده impairment of the selective selective motor control. بص على العيان ده، عشان يقدر يحرك الايد اليمين بيركروت الموفمنت بايديه الشمال. This is an example of mirror movement. Does not have a good selective motor control. العيانة دي عشان تقدر تحرك الإيد الشمال بتعمل extension of the wrist الإيد اليمين. This is a mirror movement. العيان ده لما بنطلب منه إنه يعمل extension of the wrist، شوف هيعمل إيه؟ هيعمل elevation of the shoulder. خلاص. وما ما هو مش محتاج يعمل elevate، بس هو عشان يركروت الموفمنت دي بيعمل movement of the other joints. وبعد ما نعمل له extension الجريب is maintained and cannot do a release. So this patient does not have good selective motor control, and this is an indication of the poor surgical outcome or functional outcome in general. And the selective motor control is the most important predictor of surgical outcome in the voluntary control of the hands. Sensation. What is the importance of sensation? Why we assess sensation in patients with cerebral palsy? We all know that cerebral palsy is a motor disorder. Why? There is abnormality of the sensation. Sensation is very important, and in these patients, we may test for 2-point discrimination, especially, of course, it's wide point discrimination. A stereognosis is very important, and what is the stereognosis? Is the ability to perceive and recognize the form of an object in the absence of visual or auditory information. أحط لك قلم في إيديك، العيان يعرف إن ده قلم. أحط له مربع يعرف إن ده مربع. أحط له مقص يعرف إن ده مقص، بس لازم تبقى object معروفة للعيان. Why sensation is important? Because the nervous system must consistently receive sensory information to be able to adjust and correct movement. معنى إن أنا لازم أبقى عارف النقطة اللي بتحرك منها. يعني لازم يبقى وأنا قاعد أنا عارف إن أنا قاعد عشان أقدر أقوم. فأنا عندي information طالعة للمخ عندي إن أنا قاعد ورجليا في الوضع كذا والنيس بتاعتي في الوضع كذا ورجليا والفوت بتاعتي supported ولا مش supported. كل ده مهم جدا to plan movement. And the problem here in patients with cerebral palsy at the level of sensory motor integration in the cerebral cortex. عشان ناخد example مثلا the ability to grasp. It is different to approach a cup like this and another cup like this. The glass الكوباية أنت هتapproach it بالطريقة دي، لكن لما هتابروتش فنجان هتمسكوه يبقى طريقة الابروتش بتاعتك مختلفة. بعد ما بتجمع visual information عن المكان اللي انت وعن شكل الاوبجكت اللي انت هتمسكه. sometimes انت ممكن تبقى باصص الناحية التانية وتمسك الكوباية لانك خلاص عارف مكانها ومخك عارف هي فين وعارف المسافة دي هتقدر تجيبها قد ايه من غير ما تبص لها. كل ده مهم وما تقدرش تعمله من غير sensory integration ومن غير good sensation. بعد ما نمسك الحاجة لو أنا الحاجة دي دوست عليها زيادة هيحصل لها crushing، ولو كانت تقيلة وما مسكتهاش وما عملت enough pressure هتقع مني. عشان كده الأطفال اللي عندهم cerebral palsy ممكن لما يمسكوا حاجة تكراش، ممكن يوقعوا الحاجة، ممكن تسبيل منهم. عشان تعرفوا قد ايه السنسيشن مهم، امسك كوباية مية مليانة وامشي بيها هتلاقي نفسك المية ما بتدلقش. لكن حط كتاب تحت باطك وخلي القلب adducted وامشي بيها. كل الموفمنت of the center of mass of the body will be transferred to this glass and the water will spill. فأنت في adaptation للاهتزازات بتاعة البودي بتحصل بشكل انت مش داري بيه خالص ومش حاسس بيه خالص عشان تمنع ان المية دي تتدلق. عشان كده الأطفال دول ممكن يبقى عندهم faulty approach to the objects اللي هم شايفينه وعايزين يمسكوه. ممكن يبقى عندهم abnormal grasp pattern. ممكن يبقى عندهم fall of objects. ممكن يبقى عندهم spilling and crushing. ونتيجة كل الحاجات دي they don't use the hands. They neglect to use the hands. And that's why the stereognosis and hand sensibility have been linked with the severity of motor impairment and to the neglect and disuse of the hand. And the more the degree of impairment of sensation, the more the impairment of dexterity, and dexterity is the ability to do task. And when we see a patient with severe atrophy and disuse atrophy of his upper limb or lower limb, we have to know that he has severe impairment of deep sensation. So deep sensation is very linked and very related to functional use of the limb. The last assessment is the final classification of deformity and dysfunction. The patient usually use the hands in front of you differently from what he uses in the at home. يعني انت لما العيان بيجي لك انت بتقول الام هو بيستعملها في ايه في البيت؟ تقول لك ما بيستعملهاش خالص. طيب افتح ايديك اعمل كده، اقفل ايديك اعمل كده، اقفل صوابعك يعمل، افتح صوابعك يعمل، اعمل سوباينيشن، اعمل برونيشن. خلاص انا ما عنديش حاجه اعملها له. ماشي؟ ما عنديش حاجه اسمها اعمل عمليه اخلي العيان يكتب بايديه الشمال اللي هو ما بيكتبش بيها في عيان عادي. ما عنديش عمليه اخليه يلعب بيانو. دايما لازم نبقى فاهمين ان احنا العمليه عشان تمنع حركه ناقصه، مش عشان تخلق وظيفه. ماشي؟ الكتابه، استعمال الايد بطريقه معينه، استعمالها العيان لازم يبقى محتاج الحاجات دي عشان ايه؟ يستعمل ايديه. او العيان لازم يبقى تريند، لكن مش كل حاجه نقدر نحققها بعمليه. عشان كده مهم جدا ان احنا ناسس الانترفنشن بتاعنا ليه فايده ولا ملهوش. العيان في البيت اتحسن ولا لا؟ دي حاجتين مختلفتين تماما على فكره. زي ما في اللور لمب في growth motor function classification system classifying patients into GMF CSF level 1, 2, 3, 4, 5, and 5 is the bedridden patient, 4 is the transfer ambulator, 3 is patients walking with a walking aid, 2 almost full activity but has some difficulty in climbing stairs, and 1 full activity and run and climb stairs, everything. The same in the upper limb. We have the MAX. MAX is the manual ability classification system. It assists the patient globally. So it does not assist only the diseased limb in hemiplegic. He assists, so if the patient has a very good hand, contralateral hand, he will assist the global functional use of the hand. This is a global description of the hand. The only link between these two classifications is the patient with JMFCS level 3. To be good 3, he has to have good hand function to use the walking aid. So after examination of the patient and asking the patient to do her active movement and passive range of motion, we have to see how the patient is using her hands in bimanual activities. Okay, so here she is wearing her socks. This thumb, which looked to us to be adducted, is very functional for her because she needs the key pinch. These patients usually lack opposition, and so we have to preserve for them key pinch because they will use it very well to grasp objects and to wear her shoes and to hook objects inside the hands. So we have different grades of the MAX from level 1 to level 5. Level 5, the patient does not handle object and has severely limited ability to perform. It's like type 5 growth motor function classification system of the lower limb. But the MAX cannot assess post-operative function. The patient cannot be shifted from one level to another in after surgical intervention. The patient usually will stay in his level, but with improved velocity, stability, ability to do jobs. So we need another tests to assess the preoperative state and can determine whether we really benefit of the surgical intervention or not. And there are a long list of observational tests like the assisted hand assessment scores like the Shuey-Schreiner Hospital upper extremity evaluation. And these tests assess the quality, the speed, and the accomplishment of certain tasks. And these are mainly used to assess the post-operative change and whether these patients benefit of surgical intervention or not, because even after surgery, the patient achieves the required or the missing movement, but the patient may not get any improvement in his functional status. But because these tests are not enough, we have to ask the parents, the caregiver, the patients themselves about the functional used at their normal life at home. And so there are other category of assessment, which is the patient-reported outcome measures. And the example of this is the CHECK test. It's a questionnaire asking about the functional use of their upper limb. All these classifications, we have to differentiate between the capacity and performance. What are the difference? The capacity is the ability to do a task at optimal situation of testing. But performance, the ability to do the task in real life situation. ده معناه ايه؟ معناه اني انا وانا بفحص العيان اعمل كده يعمل، اقفل كده يقفل، امسك المربع ده، حط الكيوب ده، حط ده جوه ده، افتح العلبة دي، يقدر يعمل الكلام ده كله. بس هل بيعمل الحاجات دي at his real life situation, in his real life situation? If he can do, this is performance. The capacity may be present, but in real life, he does not perform. And this may be because of many other causes زي اللي قلناها قبل كده، اللي هي sensation, poor selective motor control, weakness، حاجات كتيرة جدا تخلي العيان at the time of examination he can do things, but in real life scenario he does not do. That's why we need multiple tests to assess capacity and to assess performance. Assessment capacity, like the observational test, does not assess performance. The patient-reported outcome may help in assessment of performance. What are the goals of the patient's assessment? احنا بنفحصهم ليه؟ To set goals of treatment, to choose the optimal treatment option, to predict the final functional outcome, to measure the functional outcome. احنا بنعمل الكلام ده وبنشوف العيان ده عشان احط له goals لو هو مش حاطط goals، وعشان كمان ابقى عارف ايه اللي هيحصل واحتمالات تحسنه ايه. مفيش حاجة اسمها احنا هنعمل وربنا يسهل، ما هو ربنا هو اللي بيسهل في الاخر، بس نبقى فاهمين، ما هو ربنا هو اللي ادانا العلم عشان نبقى عارفين، عشان العيان دايما بيتوقع بعد العملية ان كل مشاكله هتتحل. اول حاجة بيقولها لك الايد بقت كويسة يا دكتور، بس العيان برضه هو لسه ما بيستعملش ايديه، ما بياكلش بيها ولا بيكتب بيها. طب ما احنا مش متفقين على ان العيان هياكل ويكتب بيها. فمهم قوي نبقى احنا فاهمين وعارفين العيان، وعارفين مفرقين ما بين الديسكاينيتيك وما بين السباستيك، وعارفين ان العيان ده عنده سيلكتيف موتور كنترول ولا ما عندوش، يعني هيتحسن فانكشن ولا مش هيتحسن، وفاهمين الكلام ده عشان نقدر نوصل المسج دي للعيان. And the aim of the surgical treatment in general, whether surgical or not, is to improve the comfort of the patient's life by improving his self-image, improving the functional activity, the caregiving activities. يعني ايه؟ احيانا العيان من الفليكسد فلاكشن ديفورميتي دي انه يلبس حاجه بكم صعبه، فانت لما بتصلح له ايديه بتسهل انه يعرف يلبس هدومه، يعرف يلبس الكم بتاعه. الكوزمتيك ابييرنس مهم جدا، لان احيانا لما بتصلح الشكل ده العيان بيبدا يستعمل ايديه اكتر نتيجه انه مش مكسوف منها. طيب الكوزمتيك ابييرنس ده حدوده ايه؟ ما هي دي المشكله، حدوده ايه؟ حد يقول العيان ممكن أو الأهل يطلبوا إحنا مش عايزين إيديه تبقى ملفتة للنظر. طب ما هو إيه الشكل اللي هيخليها مش ملفتة للنظر؟ أوكي. طيب هتقبل لحد فين؟ عشان كده لازم يبقى في كلام مع العيان، انت عايز ايه وانا كجراح او انا كفيزيوثيرابيست او انا هقدر احققك ايه، هقدر اوصلك لايه، هتقبل ولا لا؟ فاهميني يا جماعة؟ فالموضوع مش موضوع احنا هنعمل كده واحنا عندنا مقاس، لا، وانس ان الموضوع بقى حكاية personal acceptance ما بقاش فيه مقاس، ما بقاش فيه measurements. خلاص. فدي نقطة مهمة جدا لازم ناخد بالنا منها. برضو أحيانا بنعمل العملية دي عشان مع الفلكشن ديفورميتي أو الفلكشن ديفورميتي وذا إلبو بيحصل ماسيريشن أوف ذا سكين وباد أودر، فبنبقى عشان العيان ده ينفع يتنظف بسهولة، فدي بتسهل الكير جيفنج اكتيفيتيز. عشان نفهم احنا ممكن نتحرك ازاي في العيانين دول، لازم نتفرج ونشوف ال International Classification of Functional and Disability, Health and Disability adopted by the WHO. WHO عملت ايه؟ قال لك any disease, any disorder like cerebral palsy will cause body functional and structural impairments. ممكن يعمل spasticity، ممكن يعمل dystonia، ممكن يعمل flexion contractures, deformities. كل الحاجات دي body functional disruption of the function and structure. And this will affect activities. إنه يعرف يمسك، إنه يعرف يعمل ريليز، إنه يعرف يقعد، إنه يعرف يقوم. These are activities. إنه يعرف يكتب، إنه يعرف يلبس الجزمة بتاعته، إنه يعرف يغسل وشه. دي كلها activities. And these activities may affect participation. What is participation? Outside activities. إنه يبقى بيروح المدرسة، بيتعامل مع الناس، بيلعب، بيتحرك، مش قاعد في البيت مش عايز يخرج عشان ما يتعاملش مع الناس. عشان كده لما بنقيس أي حاجة في الحالة دي، احنا بنقدر نعمل ايه او ندي ايه للعيان؟ دايما بنغير الفانكشن اند ستراكشر. يعني ممكن اعمل له عمليه عشان اقلل له الاسباستيستي، ممكن اعمل له عمليه عشان احسن له الاكتيف موفمنت اوف ذا ريست او الابر ليم او اللور ليم. بس هل ده هيغير الاكتيفيتي بتاعته، هيحسن الاكتيفيتي بتاعته؟ طب هل هيفرق معاه في البارتيسيبيشن؟ هل هيبقى عايز يروح المدرسه بعد مثلا ما كانش عايز يروح؟ طب وهل الجراحة بس هي الحل اللي ممكن يغير لي الاكتيفيتي والبارتيسيبيشن؟ ما هو في environmental وبيرسونال فاكتور. العيان ده موتيفيتد اصلا ولا لا؟ منتلي عامل ازاي؟ هو عايز يتحسن ولا لا؟ طلباته ايه؟ الانفايرمنتال فاكتور، هل هو عايش في بيئة كين عليه؟ هل الاهل مهتمين بيه؟ هل هو عايش مع اهل ولا مع كير جيفر؟ عشان كده لازم نبقى فاهمين الفريم ورك ده عشان نقدر نعرف احنا حجمنا ايه وهنقدر ندي للعيان ايه. وعشان لما نأسس اللي احنا عملناه لازم نحطه في الفريم ده، مش مجرد يبقى التحسن اللي حصل حركة كانت ناقصة، لا، نشوف ده فرق مع العيان من ناحية الاكتيفيتي ومن ناحية البارتيسيبيشن والفاكتورز التانية اللي ممكن تنترفير أو تتعاون عشان تحسن العيان ده. خلاص. فلازم نفكر بالطريقة دي. The best patients or the patient who will benefit functionally of the surgical intervention هو the hemiplegic patients who have good voluntary control and selective motor control, mild level of sensory deficit, good eye movement control, no mental handicap, and adequate behavior and cooperativeness, and pure spasticity as a muscle pathology or isolated spasticity. And these are the basis of patient selection for surgery. These are the ideal patient for post-operative functional improvement. So in hemiplegic patient, mostly we aim at improvement of function. But in quadriplegic patients, in the most of cases, we aim at improving hygiene, dressing, mobilization, communication, relief pain. And sometimes in these patients, improvement of the position of the hand to use electric wheelchair will improve his mobility capacity. And we have to focus at all of this at improving the activity and participation of these patients. So to take home message, examination is very important. Discuss the specific problems and goals of treatment. Surgery can improve lacking movement, but cannot offer functional use. Be cautious in dyskinetic patients. Consider hand use in mobilization and seating. And pre-operative functional level is determinant to post-operative function outcome. And we have to be patient-oriented and not deformity-oriented. Thank you very much.